So I'm going to talk briefly about the perioperative management of steroids and adrenal insufficiency. I'm not going to include sepsis and the use of corticosteroids. I think that's a separate topic. This is really the patient who's coming in with a history of steroid use, and what do you do with that particular individual. So here's a clinical scenario, and I'm sorry I can't get you all to vote on this, but this may be a sort of a typical patient you might see in a preoperative evaluation. A 36-year-old woman with systemic lupus erythematosus who's undergoing hernia repair, and she has been on prednisone for 10 milligrams a day for 6 months, had been reduced to 5 milligrams a month ago, and the question is, what recommendations would you make regarding her surgery and the use of steroids and giving her perioperative steroid dosing? So just think about how you might approach such a patient, what you might recommend to the surgeon based on her dose duration and the type of surgery that she is undergoing. We'll come back to this at the end. The second case would be perhaps the same woman. She's undergoing hip replacement, maybe because of her long-standing steroid use, and she has avascular necrosis of the hip, and to the point that she actually needs a hip replacement. She's been on prednisone for 2 weeks, and the taper was started at 60 milligrams daily, and she's currently on 20 milligrams. So she's been on 20 milligrams or more for at least 2 weeks prior to surgery. And based on that, what would you recommend to this particular patient? What's her risk? How much steroid? Do you give steroids at all in such a situation? So when we think about adrenal insufficiency, there are a couple things we need to take into account. One is past or current corticosteroid or glucocorticoid use in the patient. That's obviously the patient at risk. We do have patients who have adrenal insufficiency who haven't been on steroids, but this is the patient we're talking about. The suppression is going to vary depending on what dose and what duration. Those are the two things you need to know. How long have you been on the drug, and what dose am I using of the drug? And for us, the big concern is always the syndrome of adrenal crisis or acute adrenal insufficiency, the patient who drops their blood pressure, gets acutely ill. But one of the points I'm going to make in a moment is these patients may actually have much more subtle signs and symptoms, and you at least have to be aware that could be the problem. And if a patient's blood pressure is not low, it doesn't mean they don't have adrenal insufficiency. They could certainly have other symptoms, which I'll mention in a moment. So what's the problem here? We all know that the ultimate release of cortisol is based on a hypothalamic release of cortisol-releasing hormone, corticotropin-releasing hormone, and then you have the release of ACTH or corticotropin. You get the adrenal gland secreting cortisol, and then you get feedback. And like all endocrine, you have to keep track of what feeds back onto what. In this case, it's pretty straightforward. The cortisol basically feeds back to both the pituitary and the hypothalamus and says, hey, turn off, there's enough of me around, and then you have this steady state of hormone, like really every other hormone in our body. Well, if you have someone on exogenous corticosteroids, well, now you're continuously providing an inhibition to the gland, and endocrine glands, if you turn them off, they often will stay off for a while, especially the pituitary and then the hypothalamus, and these guys then don't make any of the stimulating hormones, and the adrenal gland as well will turn off, and you don't make any corticosteroids when you stop the drug because the gland has now suppressed itself, turned off all the messengers that make you produce these things. And then we'll talk about how long does that last. So in this case, prolonged corticosteroids, you turn off the ability to produce cortisol. Not in everybody, but certainly that's the patient at risk. Now, this is what I was talking about, that it's not always shock. It's pretty obvious. Someone comes out of the OR, their blood pressure is 70/30, and you say, oh, they're on steroids. Let me give them a shot of hydrocortisone. The blood pressure comes up, and you've got a diagnosis pretty much right there. Those ones are the easier ones. Well, it turns out there are many symptoms that you can see with adrenal insufficiency, particularly in the milder forms, and you can see that pretty nonspecific. This is what you see in pretty much every patient coming out of an OR, right? Nausea, vomiting, anorexia. They may have abdominal pain and headaches. So at least one has to maintain a level of vigilance in someone who's been on steroids, or you're going to be treating them anyway, potentially. But when you do see nonspecific symptoms, they don't make sense, it doesn't fit that particular patient, keep in mind the possibility of an adrenal insufficiency. Now, as far as the dose equivalence, and this becomes important when we start to figure out how long has a patient been on steroids and how much, we need to know how much is based on what drug they're on. And this is one of those things that I almost always have to go and just look up on Google because I can't keep it straight. I pretty much know that 5 of prednisone is 4 of methylprednisolone, and then you kind of, each of you will remember a different relationship. But the point is that hydrocortisone, which is really equivalent to the cortisol that our adrenals make, of 20 is equivalent to about 5 of prednisone, and I'll show you in one of the upcoming slides that our body generally will produce 10 to 12 of hydrocortisone, milligrams of hydrocortisone equivalent. So you can see that the doses all shown here are actually not therapeutic, but supranormal for a patient because 5 is around 20, and that's above your 10 to 12. So as I said, normal production on a daily basis, 10 to 12 milligrams of hydrocortisone. And when we're thinking then about when are we going to suppress our adrenal glands, it's going to be when we give more than physiologic doses. And the guidelines generally would say that if you have I've got here just one greater than sign, a slight excess of corticosteroids. In this case, the numbers that have been quoted are 5 of prednisone, 20 of hydrocortisone, and 0.75 of dexamethasone, as shown in the previous slide. You need to be on that dose for about 3 to 4 weeks before you get adrenal suppression. So if someone's been on 5 milligrams for the last 2 weeks, you'll probably find they've got a Medrol pack for their poison ivy. They're probably fine. They were on probably for 7 days. They weren't on a very high dose. It was tapered off. They're probably going to be fine. But if you've got someone for longer than 3 to 4 weeks on that sort of dose, which isn't a very high dose, that patient's going to have the risk of being adrenally insufficient. Now, when you start to talk about higher doses, so we're looking at prednisone of 20 milligrams, so multiply by 4, that's about 80 milligrams of hydrocortisone, you don't need a very long duration. 5 to 7 days on that dose of drug, you could suppress your adrenal gland. You may not produce enough cortisol when you go into surgery. That's a patient who's going to need some supplementation of corticosteroids. So again, as I said, it always depends on what dose and what duration the patient had. Again, low dose for more than 4 weeks, high dose for more than a week. That's the patient I'm going to worry about. How long are you going to suppress them for? Well, if you read the literature, it says anywhere 9 to 12 months. Usually I think it's around 6 months for most patients would be at the tail end of duration. 9 to 12 is probably way out the tail end. But certainly there are patients who 10 months after finishing a long course of steroids still is adrenally insufficient and needs to be supplemented around the time of surgery. So you have your patient who had steroids 6 months ago. You didn't get the history. They dropped their pressure in the MICU or the SICU. That person certainly is at risk having had steroids 6 months ago. And this just requires a good history. Some pre-op forms will have you been exposed to steroids in the previous 6 months or 12 months, and that'll help you get to this answer. The pituitary will return before the adrenal gland, so measuring things like ACTH levels is not going to actually help you. But really, if you really need to know if someone's adrenal gland has recovered, you can do a stim test, and we'll talk about that in a moment. So what happens in surgery? So obviously it's not a physiologic state. During surgery you get a rapid rise in endogenous cortisol production. This could be up to 50 milligrams a day. So if you think about your baseline around 10 to 12, you're getting about a 4 to 5 times elevation in cortisol production. And if your gland can't do that, you're not going to have enough around, and that's when you get into trouble. Now with a major surgery, we're talking about 75 to 150 milligrams a day, so really a huge surge of cortisol, and these are patients that are probably going into the most trouble. So a lot will depend on what type of surgery a patient's undergoing as to how you're going to supplement them. The main increase is early after anesthesia induction, and therefore when you're going to give them the dose you give them at the beginning of surgery, make sure there's steroid on board, and the patient will do well. And then it takes about 24 to 48 hours before the steroid levels level off, in which case if you're going to treat someone who's having a major surgery, you may need to keep them on some sort of supplement regimen through those first 24 to 48 hours, and I'll come up with some guidelines in a moment. And really what you're doing is you're mimicking that physiologic response. We try to do that. We probably can never quite mimic it, but we do as best we can, knowing that this is what's going to happen in our patient. Doing stim testing, you can either do a high or low dose cortisol stim test, and we check the levels of cortisol at times 0, 30, and 60. And really what we want to see is the cortisol levels go above 20. Some people say an increase of 6, 7. There are different rules. But certainly if you can get your cortisol above 20, that's going to tell you that this person probably was stimming adequately. They're making enough cortisol in their gland. And if you've got a baseline cortisol that was at that level, this patient's going to be making enough to get him through surgery. Now, I'm not talking about the patient who's sitting in the ICU on 3 pressors and septic. That's a very different patient. This is someone who's coming into your pre-op area who's walkie-talkie. Should we do that test? Well, testing's expensive. It's inconvenient. The patient has to come in. You've got to figure it out. You've got to give them the test. You've got to draw their blood. You're probably going to have an IV put in. So not very convenient. Certainly, it can be expensive to check cortisol levels. You don't get the results right away. It may take days depending on where you send the labs. And stress dose steroids are actually very easy to give. They're very inexpensive, and there really has not been shown to be any adverse effect of giving the type of doses of steroids that you might give for that shorter duration. So many believe don't bother with a stim test. Unless you have to know, you're probably just going to give someone steroids perioperatively and get them through that period of time if you've deemed them to be at risk based on their dose and duration of therapy in the past, and then what type of stress they're going to have. So this is just sort of a basic look at this. You're probably all much more informed than I am as to what's a minor, moderate, or major surgery. You know, we always say to our patients, there's no such thing as a minor surgery, but at least based on classifications by people who discuss these things and categorize these things, there certainly are surgeries that are more significant than others. And minor would include things like hernia repairs, moderate would be hip or joint replacements, and severe surgeries, really any cardiovascular surgery, aneurysmal surgery, vascular surgery would be in that group. And you can see that the stress dose steroid is going to be escalated based on what type of surgery you have. And you know, if you're in doubt, give the higher dose. You know, if you think it's severe and you're trying to debate, is this going to be a severe or not, give the higher dose, obviously. And the duration of supplementation will be based on how severe it is, because they're going to get that surge and then they're going to need extra steroid through those first either 1 day or 1 to 2 days, or in the most severe surgeries, you really want to keep them supplemented through those first 24, 48, maybe even 72 hours, depending on how the patient is. So how do we, what are the recommendations? If someone is already on underlying steroids, they take those steroids the day of surgery. We'll talk about that in a minute as far as what else you might do. And then again, minor stress is 25 hydrocortisone. Some people would say you may not have to give any. These are patients who are already taking exogenous steroids. Okay, so this is a little bit different. Someone who's already on 5 of prednisone for their lupus, you may not have to give them any steroid supplementation. Moderate stress, they need a little bit more, and then major stresses, they're going to need more supplementation. Very similar to what you might do for someone who's not on at the time, but had a prior exposure of steroids. Now, there are some studies, there are very few really well-done randomized controlled trials that have looked at the use of steroids versus no steroids in those patients who have prior exposure on steroids at the time of surgery. There was one review that evaluated all these studies, and you can see not a whole lot of patients, 315 patients. And there were 2 patients that developed hypotension, and both those patients just didn't take their medication the day of surgery. So really what the conclusions of these studies say is, don't do an ACTH stim, have them take their steroids the day of surgery, and if you're really concerned, or if it's a major surgery, you're probably going to give them some steroid through the first 24 to 48 hours to make sure that they replete. And this would be a basic algorithm. I think this is sort of the bottom line. As I said, high-dose steroids, that's more than 20 milligrams for more than 1 week. That patient's a concern. More than 5 milligrams for 4 weeks, even if that was 9 months ago, that patient is someone who we're going to be worried about, and we're going to then risk stratify them based on what type of surgery they're undergoing. And listed here are the different doses, which will just escalate based on the type of surgery that the patient is having. So if we go back to the initial scenario, this is probably a pretty common one that you'll deal with. This is the young woman, or young, for me that's young, who has lupus on 10 milligrams of prednisone. You could argue even on 5 milligrams of prednisone for 6 months. She's currently on 5 milligrams, and the recommendation for her would be what, based on what I said. So she's been on more than 4 weeks, more than 5 milligrams. She's at risk. She's undergoing hernia surgery. That's a minor surgery. And in that case, I would just give her a one-time 25 milligram dose. You could argue, based on what's out there, just give her the tell her, take your 5 milligrams in the morning and don't worry about it. I don't think 25 milligrams of hydrocortisone is going to be particularly harmful in any patient. And I tend to think, when in doubt, one dose of steroid is not going to have any impact, certainly not on wound healing, on their glucose. Maybe their sugars will go up a little bit, and you can take care of that if they're diabetic. The second patient, the same woman, but now she got avascular necrosis from the steroids, and she needs a hip replacement. Well, in this case, she's been on 60 milligrams, and now 20. This has been more than a week, more than 20 milligrams for more than a week. She's at risk even if this was 5 weeks ago. She now has the risk of having adrenal suppression, and she's undergoing what would be considered a moderate risk surgery. And in that case, you're going to give her a 50 milligram dose hydrocortisone and probably trail it out for a day with a couple 25 milligram doses, Q8 hours, to make sure that you have her stress hormones intact. So in summary, I think the most important points, fairly straightforward: chronic steroids or past steroids for a certain duration, low dose, longer duration, high dose, short duration treatment. Those are your at-risk patients. And once you've determined risk, look at the type of surgery they're getting and determine how you're going to treat them based on that particular surgery.